Good morning. My name is Dr. Renelle Miles, and I want to welcome you to the NIH Office of Disease Prevention's Medicine Mind the Gap seminar series. This seminar series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods in prevention science research and to support the development of better methods. Before we begin, I have some housekeeping items. To participate by Twitter, follow us at NIHPrevents and submit questions using the hashtag NIHMTG. You may also email questions to prevention@mail.nih.gov. There is also a link to a feedback form at the bottom of the videocast page where you can submit questions during the talk. At the conclusion of today's talk, we will open the floor to questions that have been submitted via email and Twitter. Lastly, we would appreciate your feedback about today's seminar. Following today's talk, please visit the ODP website at prevention.nih.gov/mind-the-gap and click the link to the seminar evaluation under the resources section. Your insights will help us to continue to improve this seminar series. At this time, I'd like to turn things over to Dr. Carrie Klabundy, Senior Advisor for Disease Prevention here in the Office of Disease Prevention.
Thanks, Renelle. Today we have the second part of a three-part Mind the Gap series of sessions on screening and disease prevention. Dr. David Grossman will present on guidelines for screening in children. Last month, Dr. David Ransohoff presented on making guidelines for colon cancer screening, and in November, we will have a seminar by Dr. Ruth Etzioni on defining and measuring overdiagnosis. Dr. Grossman is a senior investigator at the Group Health Research Institute, executive medical director for population and purchaser health strategy, and a practicing pediatrician at the Group Health Healthcare System in Seattle, Washington. In his current research and administrative roles, he leads and provides oversight for the design, promotion, delivery, and evaluation of population care services, including studies of the impact of health benefit design changes to promote prevention. He's also professor of health services and adjunct professor of pediatrics at the University of Washington. Dr. Grossman holds numerous leadership positions within the professional community. He has a national impact on health and healthcare as vice chair of the U.S. Preventive Services Task Force. The task force, which is sponsored by the Agency for Healthcare Research and Quality, is an independent panel of national experts that reviews clinical evidence and provides recommendations on a range of preventive services. Dr. Grossman also has served several terms as a member of the Board of Scientific Counselors of the CDC's National Center for Injury Prevention and Control. He earned a Bachelor of Science degree from the University of California, Berkeley, a medical degree from UCLA, an MPH degree from the University of Washington, where he also was a Robert Wood Johnson Clinical Scholar. It's my pleasure to welcome Dr. David Grossman and turn the session over to him.
Thank you very much, Carrie. It's a pleasure to be here, and thanks to all of you for joining for this morning. I think, as many of you know, the focus of today's discussion is really around improving the evidence base for pediatric clinical preventive services. Before I get going here, I just wanted to just to show this disclosure slide. Carrie mentioned that I have an affiliation with the U.S. Preventive Services Task Force, which I will be discussing. I want to emphasize, however, that the views that I expressed in the seminar do not necessarily reflect those views of the USPSTF, nor my employer, Group Health. I also have no financial disclosures relevant to this presentation. So for today's talk, I'd like to kind of cover really three major areas. One is the evolution of evidence in pediatrics and clinical preventive services. How did we get to where we are right now? What the snapshot of what the current state of evidence appears to be, largely through the lens of the task force, which does a careful combing of the literature and the landscape in prevention. And then finally, talk a little bit about some of the challenges and opportunities to improve the evidence base for prevention in pediatrics. So I want to start at the foundations of this to make sure that we have some level setting going on here around terminology. And I'll start with what we mean by evidence-based medicine. So this quote is directly out of David Sackett, who many consider to be the father of evidence-based medicine. And he defined it as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So much of the focus of evidence-based medicine really did start on individual study appraisal and appraisal for quality and characteristics. However, as I will talk about, as we've accumulated a considerable amount of evidence in individual studies, we really also need to be thinking about the body of evidence, not just a single study, but obviously the body of studies that comprise evidence around a single question. So I think many of the people in the audience are familiar with individual study quality appraisal. I'm not going to belabor this, but suffice to say that really primarily we're looking at issues such as internal validity that focus on specific design-specific criteria that many people are familiar with and are focused on what are the criteria, for example, a randomized controlled trial versus a cohort study. But many of these criteria all have the same focus, which is really around minimization of bias and confounding. And then there's the external validity, which is really focused on the generalizability of studies to a specific population, to the clinicians and the setting in which they practice. And out of this, many organizations that appraise evidence have developed a hierarchy of study design that automatically provide the strength of evidence associated with certain specific study designs. So with many of those organizations looking at randomized controlled trial as being the perhaps at the top of that hierarchy, but recognizing also that not all study questions can be answered with an RCT. So evidence-based medicine has evolved, obviously, from quite a bit. And in the so-called old days, but certainly in my career, I've witnessed the evolution from coming from an emphasis on clinician guidance coming from consensus development statements that really were fashioned by bringing experts around the table to hammer out what clinicians should be doing. And now we are really in the middle, if not or at the advanced stages, of providing guidance that's really based on systematic evidence reviews. So as that really, as outlined in a series of articles back in the mid-90s, really involves the integration of evidence across studies and being systematic in their approach so that we minimize bias in our selection of studies and developing recommendations. So that involves standardized approaches to appraising a body of evidence, which involve a whole set of meta rules, so to speak, and then also standards for meta-analytic methods for pooling data across studies. So those concepts were pioneered early on by a number of different organizations that I list here, and this is not an exclusive list by any means. But I do want to point out a couple of organizations that really got an early start on this with regard to how to take systematic evidence review and move it forward into evidence-based clinical recommendations. And I do want to credit the Canadians who actually started their task force on preventive healthcare way back and started to develop this approach towards developing guidance around prevention. The U.S. Preventive Services Task Force and the Canadian Task Force went through a period of hiatus and now has reopened and is active in developing new recommendations with a whole set of advanced procedures and methods. The U.S. Preventive Services Task Force has been in business a long time also, and its methods have evolved considerably from its inception to where it is now with an open, transparent procedure manual that's constantly changing and evolving as methodologies evolve as well. And then finally, of course, the Cochrane Collaborative, which evolved as a voluntary collaboration among clinicians to find the best evidence by bringing together randomized trials, especially with a special focus on randomized trials across a variety of different domains. So all of that has evolved into a publication that many of you are probably familiar with called Clinical Practice Guidelines that we can trust. This was a publication that came out a few years ago from the Institute of Medicine, which really laid out what the standard should be around evidence-based medicine as embodied in clinical practice guidelines. So now I need to shift gears a little bit, and as we talk about prevention, define what I mean by clinical preventive services. Really, the definition here that I'm using is the same that the task force uses, or both task forces use, the Canadian and the US, which is that clinical preventive services comprise those activities led by primary care clinicians that involve screening, behavioral interventions related to prevention, and then also chemo or immunoprophylaxis. So immunizations are part of that activity, of course, but also medication prophylaxis can fall into that category. And then there's certain preventive services that actually involve more than one of these activities and are comprised of mixed modality. And so together, those four constitute the body of clinical preventive services, as distinguished from services that are offered through community channels, for example. So what about the evolution of demand for evidence in prevention, and how has that evolved over time? And I think it's important to spend a little time on this, in part to understand the supply of evidence and how it's evolved. This, I'll freely admit, is my own thinking. It reflects my own thinking, and certainly is something I've evolved over time as we've developed these activities related to recommendations for prevention. But I'd like to posit or hypothesize that really clinicians have demanded and prioritized evidence of those that actually are of highest severity, acuity, and also those that are contagious, that affect multiple people, have the capability of actually turning into public health nightmares. The clinicians are, of course, primarily in the face of treating sick people, and when they see conditions of that type of severity and acuity, they feel compelled actually to focus most of their attention initially in that area. So that, of course, leads to a demand of specific kinds of studies, and we're seeing this replayed, of course, in our own era, as we have, particularly in the area of infectious diseases, we have evolving and emerging infectious disease. We see the same kind of process play out. Some of the focus starts with studies of diagnostic tests in order to be able to correctly classify people who actually have the disease in order to apply their therapy to the right people. And there's an obviously important emphasis in that area. The second is around treatment trials to reduce the short term of morbidity and mortality, so that results can be seen fairly quickly from the application of those treatment trials. The third is prevention trials. Prevention trials are, in a sense, really fall behind the treatment trials and diagnostic tests, particularly if there is a treatment. But in some cases, there is no identified treatment, in which case prevention trials become an important priority. Polio is an example of that, and the development of polio and the polio vaccine reflects the fact that polio did not have a treatment. And the evidence, the demand for evidence around polio immunization and immunoprophylaxis quickly took priority as we were, at that era, completely unsure how to treat polio as a disease. So in some ways, those three foci of activity all are really emphasize the importance of addressing high severity, high acuity, and contagious diseases. What falls behind that priority are those other diseases that are also of high severity, but with and shorter term mortality risk. In some ways, children don't take a big role in those types of studies. Adults tend to have more of those types of risks. And I'm talking more largely non-contagious diseases. Cardiovascular disease is a prime example of that. And the third is chronic diseases with very delayed consequences, in which we are unlikely to see the immediate effects in the toxin. So the demand and the priority for evidence really kind of falls in those. And that's, I would argue that in pediatrics, that's a little bit about why we got to where we did. So two examples of high demand of evidence in children are these. One is in the area of oncology. Because in part acute lymphocytic leukemia does have if untreated, does have relatively short-term consequences and can be a catastrophic disease for childhood. An early emphasis was put on the development of therapeutic trials for ALL and the development of evidence in a rigorous fashion, way ahead of many of the other diseases in pediatrics. Another example is in acute infectious diseases I mentioned a little bit earlier, both antibiotic therapy and passive and active immunization. If you look back to where the earliest trials actually were executed back in the 50s, they were in these areas. The use of streptomycin, for example, was developed through randomized trials, and then also, of course, as I mentioned earlier, polio vaccine was one of the first randomized trials, particularly in the area of immunization. So pediatrics got an early foothold in developing high-quality studies, in part because of that demand issue, and children having a special place, and given the long life, or the number of life years that was eclipsed by some of these diseases. So in pediatrics, as we began to solve those issues, immunizations became very effective, antibiotics also. We largely were able to replace or displace those acute infectious diseases with what Robert Haggerty called the new morbidity of pediatrics. So Dr. Haggerty is a very famous pediatrician who asked pediatricians to sort of look beyond the era of acute infectious disease and say, what else should we be doing in the context of here, and outlined a number of areas, including those here: chronic illnesses, behavioral conditions, lifestyle risk factors that lead to, for example, obesity, and then also behavioral and developmental pediatrics. But one might argue how new those things really were. And in fact, they probably weren't new. They were really more overshadowed by some of the urgency of those acute infectious diseases. But nonetheless, as this became to take over the content of care for ambulatory pediatrics, increasingly then there became a new demand for treatment as well as prevention evidence for these types of conditions as well as risk factors. That was, of course, in the mid-70s, which was about the same time that both the Canadian and the U.S. Preventive Services Task Force started to look into clinical preventive services. So let me now lay out for you what, from the standpoint of how different groups look at this issue, and I want to use the USPSTF in part because I know them best, but also because I think many groups, not just in pediatrics, but out in adult medicine, look at the USPSTF as, to some degree, a gold standard of how to appraise evidence and transform them into clinical recommendations. So the USPSTF really looks at two issues in making their grades and in their recommendations. One is the magnitude of the benefit of a particular service, how much health benefit can be accrued by delivering that service. And the second dimension is the certainty of that benefit. How certain are we, based on the evidence, that that benefit is likely to yield the results that we are seeing? And the task force sorts its grades based on a grid that combines those two appraisals, magnitude and certainty, and comes up with grades of A and B for recommended routinely, a C, which is recommended selectively, and a D, which is do not recommend. Those services are not recommended for use in patients. So in addition to that, if the certainty of benefit based on the evidence is low, then we come up with an I statement, which is translated as a statement of insufficient evidence. An I statement can be somewhat frustrating to clinicians just because it doesn't provide clear guidance and ask clinicians to exercise judgment based on the little information that we have, and use it as an opportunity to share that with patients in an open fashion about what we do know about potential harms as well as potential benefits, but acknowledging that we don't have sufficient evidence to be able to make a recommendation. So that process is arrived through a careful understanding of what the potential benefits of the service are, and also, importantly, taking into consideration the harm. Historically, many clinical guidelines and recommendations and consensus expert-based recommendations were based heavily, perhaps overweighted on benefit, in part because harms are harder to find. The evidence around harms is not as routinely gathered as the harms around benefit. Randomized controlled trials frequently aren't powered to actually detect harm. And also, as we've learned with drug studies, we frequently do not learn about harms until they've been in the market for a long time to better understand what those long-term harms might be. But the task force and other groups like the task force really have to bring harms into view in order to really understand what the quote net benefit is, and not just what the clinical benefit is. So the certainty, of course, is really based on that overall body of evidence around the magnitude. And as I indicated earlier, the areas that are looked at carefully are internal and external validity of the evidence base, not just of the individual studies, but applying similar criteria across the evidence base. How much heterogeneity there is across studies. In other words, are studies telling pretty much the same information? And the answer is the magnitude similar, is directionally similar. And then to better understand coherence, understand whether or not these results appear to be consistent, internally consistent, when you stack them all, when we put it all together, and I'll discuss that further in another slide. And then finally, an important consideration of the body is what is the size of that evidence base? I would argue that in pediatrics, in general, the bodies of evidence tend to be considerably smaller, fewer studies, smaller sample sizes than adults, which to some degree can't compromise the certainty of a body of evidence. So, the question is, are there disparities in the evidence supply for preventive services among children? I actually looked at this issue quantitatively. It's not something I've done before, but in preparation for this talk, I actually did a sort of an accounting of task force recommendations, again, because the task force does look widely at a broad area of recommendations, and because it's been at it for a while and has a large library. What I wanted to share with today, and again, these are my calculations, and I'm not speaking on behalf of the task force, but I think overall, we have about 128 separate USPSTF recommendations and I statements, and now I'm talking about grades, so that in a particular domain, there may be multiple grades focused on, for example, different populations, pregnant women or adults, or different grades that are related to different types of service. But overall, what we have is about 38% are insufficient evidence statements, and about 62% are graded with an A, B, C, or D. That's across the overall library. And of those 128 statements, about 36% have some relationship to pediatrics. 21 of these are focused on infants and children, and by that I mean non-adolescents. And the task force does look at children and adolescents fairly as separate populations. Then another 35 address adolescents, but in the context of adult recommendation statements, meaning that frequently these are recommendations that might be for adults, but they're actually brought down to age 15 or age 14, in part because the extrapolation appears to make sense, in part because the evidence is combined. And then we have one recommendation that's actually focused just on adolescents, which is scoliosis screening. So the absolute number of recommendation statements is smaller in pediatrics, especially in young children. So the volume of evidence and the number of recommendations that can be made is indeed quite a bit smaller than it is in adult medicine. But the relative proportion of I statements is actually somewhat similar between adults and children. I think it's important to recognize that frequently the task force and other guideline groups may be hesitant to take on an appraisal process if it appears to be at the outset fairly obvious that there's not going to be evidence to actually make a recommendation. Most groups want to be able to come forward with something, and if you tackle a service for which there's a priori very little evidence, then in fact that this the absence of or the absence of that recommendation as an I statement may not be reflected because it's been pre-selected out. So what are the barriers to achieving high-quality evidence-based pediatrics? And let me digress just for a second and say that although I showed you that the percentages of I statements is roughly similar across those groups, if you dig into and look at volume of evidence, and this is now purely anecdotal on my part, I think in general, as I said earlier, you will see that the volume of evidence, numbers of studies, size of the studies, overall in children and adolescents tends to be considerably smaller than for adult medicine. So I think that to some degree, this is really an issue of supply and demand, and it's complicated, and I'll talk a little bit more about this. But historically, supply has been somewhat low, particularly in these areas that I talked about that are the new morbidity. We have increasingly a really strong evidence base in some of the areas of high acuity medicine, particularly in infectious disease, but perhaps less of a supply. And I think that the question is how do you strike that balance between supply and demand, and where does that actually demand come from? So let me start. I want to be able to show you a little bit about an analytic framework so that you can understand a little bit about what a gap actually means when we talk about it. What are the processes and problems associated with getting to essentially to a letter grade? Well, this analytic framework is a generic framework, and it happens to be for screening. Similar frameworks or similar generic frameworks for behavioral intervention and also for chemoprophylaxis. And the task force does not deal with immunizations. The Advisory Committee on Immunization Practices does that, and we refer to them for those types of recommendations, but we do look at chemo or medication prophylaxis. And as you can see here, ideally what we'd like to do is really identify evidence, looking at what we call key question 1, which are really screening trials that take individuals and randomize them to be screened or not screened, and then look at their health outcomes, which include morbidity, mortality, health-related quality of life, and potentially other outcomes. But the problem in pediatrics is that frequently we do not have screening trials, as there are in some areas. For example, in adult medicine, and particularly in cancer screening, you will find many screening trials. What you will not find in pediatrics is many screening trials that actually are developed as KT1 is developed. So if you do not have that, then your next option is to look at what's called indirect evidence, which is to compile evidence across this chain here, looking at the evidence around screening, looking at the evidence around treatment, and then if treatment involves some intermediate outcome, the intermediate outcome might be a lab value, for example, or a behavioral outcome like eating more fruit or exercising more. The next question is, well, what does that really mean in terms of health, in terms of reduced morbidity or mortality? What does it mean to eat 2 extra fruits a day? How does that really affect your health? So the evidence has to be compiled across that entire indirect pathway. And then in addition to that, you really need to be thinking also about, well, what are the harms around screening? What are the harms about treatment? And that information, of course, comes into the compilation of what we know about net benefit, or what is the benefit minus the harm. So in essence, this is a process that involves considerable data collection across a number of different types of studies. Some of it can be complicated if you can find screening trials. But again, as I indicated, in pediatrics, we don't have them. Finally, I want to point out that coherence is an important part of this analytic framework. In other words, this information has to be assembled and put together and made sure that, in fact, all the evidence, in fact, fits together in the right way from a number of perspectives, including temporal sequence and other sorts of things. So, as I indicated earlier, these are the areas where evidence gaps might appear. It could be around the screening tools, could be evidence around treatment effectiveness for domain. You could have great screening tools that lack evidence around treatment. And then, of course, harms for, as I indicated earlier, are both potential gap areas. And then finally, that area around intermediate outcomes or health outcomes, as I'll talk about in a minute, is a special area of difficulty for pediatrics. So how would we classify evidence gaps? Well, if you were to look at the body of evidence gaps out there in pediatrics, there's really two ways to look at it. One would be to look at a gap in which its closure could convert an I statement to a letter grade. In other words, you can move from an insufficient evidence statement to one in which there's either a positive or a negative recommendation. Some areas have so many gaps that it would require many different types of studies to be able to close. In other areas, there's actually one primary area. In other words, so for example, treatment effectiveness. We have the screening tools, we have information about harms of screening, but we're lacking information about treatment effectiveness and perhaps treatment harm, and that's the area that needs to be closed. The other area is that it's not just about I statements. Improvement of the evidence body could actually enhance the magnitude of certain existing recommendations. In some cases, we, as I indicated, a B and an A reflects different levels of certainty. And in the cases of A recommendation, we have high certainty that benefit is there. In other areas, the certainty is more moderate. And in those cases, the evidence base could be strengthened in order for us to increase both our certainty as well as our precision. So I do want to point out that the task force does routinely identify and report evidence gaps. These gaps are synthesized in the context of each recommendation. And in addition to that, they compile gaps and put them together into an annual report to Congress, which as part of its authorization requirements is a report to Congress that highlights areas that are in need of further research. So there are a number of ways actually to pull these gaps out and to identify them. Some of them are perhaps viewed as more critical and pressing than others. But generally, by looking at the level of the evidence statement, you can find most everything, including those that don't end up being I statements. There are always still some gaps that are called out. So what are the special challenges to achieving sufficient evidence in children? There are really two major domains. One are what I would call macro barriers, and then there's methodologic barriers. For the individual researcher, it's really a major focus on the methodologic barriers. But for policymakers and those working in, at a different level here, it's important to understand that there have been macro barriers. I'm not going to spend much time or at all to address some of those in Q&A. But clearly, those examples of macro barriers would be policymaker attention. In other words, perhaps there's an emphasis or disproportionate emphasis on certain types of diseases or certain types of conditions or certain types of populations. The other, of course, is funder attention. Those interact. I mean, to the degree that policymakers have a particular interest, that, of course, can affect funder interest and attention as well. And then another important area is workforce. To what degree is the workforce really prepared to engage in developing high-quality studies, particularly clinical effectiveness studies, to really address these gaps? So the methodologic barriers is really where I'm going to move to next, which are things that individual researchers and groups of researchers can address. So a group from the task force did publish an article a few years back, which did highlight some of the issues and concerns. And this reference is one that actually does lay out a number of problems or areas that need to be resolved in order to improve the evidence base in children. And I think many of those of you that are involved in child research will immediately recognize some of these issues. Of course, one of them is low condition prevalence. So children tend to be healthy. The onset, the incidence of diseases, of course, is not, in many cases, is not that high. And that has direct implications for statistical power, particularly when you're trying to do single-site studies. Of course, that was immediately seized upon by the groups that actually did oncologic research for children by banding together, and I'll talk a little bit more about that. The short-term outcomes of many studies poses a problem because many organizations that do this type of appraisal of evidence want to see what happens to individuals after the treatment is stopped and then follow them over some time. This is a particular problem for drug studies, and there's already a lack of I would say that for children, drug studies already tend to be a problem, although some of the recent legislation that actually focuses in that area is a significant help. But licensing studies for pharmaceuticals tend to be focused on very short-term outcomes and don't require a long-term follow-up of children, and therefore that compromises the ability to understand what's the long-term effectiveness of any intervention. The other problem, of course, is following children to longitudinally from childhood to adulthood, because many of the benefits that could potentially be realized for children would not accrue until later in life. And that requires tracking children over time to adulthood. And those studies are very difficult to identify, are often of secondary data and cohort studies, but ones that are critically important to understand what's the linkage between intermediate outcomes and the long-term health outcomes. The other is the generalizability of findings across all development stages. Many studies actually may be focused on a particular age group, but the findings cannot necessarily be extrapolated to other age groups. And in the autism recommendation, insufficient evidence statement that the task force made recently, this was a key issue around the body of evidence for treatment of autism with intensive behavioral therapy was really focused on older children, whereas the case for screening really depended on identifying and treating children at a younger age. The absence of modeling studies, as we have in adult medicine, can sometimes pose a barrier or a problem using the evidence that you have and being able to make more of it. Health outcome metrics, another area that perhaps is underdeveloped compared to adult medicine, particularly quality of life tools and other types of tools that help us identify appropriate outcomes, and as well as giving some special consideration that it's not always for children about morbidity and mortality. There are many outcomes for children that are important from a social behavioral perspective that are linked to health outcomes. The heterogeneity of screening tools that are frequently used, and this is a problem in adult medicine as well, where we see lots of good studies on screening, but each one uses a different tool, and so it makes it difficult to assemble the evidence across those. And of course, heterogeneity of interventions, particularly behavioral interventions, can be an important barrier. So coming back to this issue, I think I just wanted to point out that these relate in many cases to the key questions at hand that I showed you earlier, but I want to emphasize again this area number 6 is of particular importance for a number of interventions, particularly in cardiovascular disease prevention for children, where we really need to better understand what the long-term consequences of having an elevated blood pressure or an elevated lipid level are in childhood relative to adults. So should the evidence standards for pediatrics match those for adults? And I think that I think most people would argue that they should, and the children should have absolute parity with regard to our ability to practice clinical evidence-based medicine. But then, if the answer to that is yes, then what are those investments that are required to prove the availability of evidence? That in and itself could be an entire hour discussion. But I think that just to develop some starter thoughts on that. Clearly, investments in screening trials, as I indicated earlier, the KQ1 question is frequently, almost always missing from pediatric evidence reviews, in part because we just don't do very many screening trials. We do very few. But there are a number of areas where it would not at all be impossible to actually execute screening trials. We also need more cohort studies with adequate follow-up that sometimes challenge funding agencies' 5-year cycles so that we can get very long-term data and a commitment from funding agencies to actually capture that information over time. We also need to develop infrastructure for multi-center prevention trials in children, as the oncologist did for oncology treatment. We've seen tremendous success in children's oncologic research and outcomes, in no part, and clearly in part due to the collaboration across multiple sites to account for the small sample sizes of each study site. We also need to work on aligning study designs to minimize heterogeneity, as I indicated earlier, across screening tests, treatment modalities, and outcomes, clearly which serve as a barrier to being able to understand the overall coherence of specific questions. And then finally, as I indicated earlier about K26, we really don't have a great set of robust epidemiologic reviews that really can associate for us the intermediate outcomes with the longer-term outcomes. That depends in part on those long-term cohort studies that I discussed earlier. But this is going to be a key issue for this field if we're better to understand how the initiation of preventive services in childhood affects outcomes in adulthood. I do want to point out that that there has been strong interest in this area by NIH, particularly the Office of Disease Prevention, which has taken an important role in advancing this issue of evidence gaps with funding agencies, in particular NIH, as well as other federal funders. This article, which has appeared in a supplement of the American Journal of Preventive Medicine, highlights how this coordination is taking place across these funding agencies, and using the evidence gaps that are identified by the task force to be able to make research more focused and likely to be more successful in closing those gaps. So, in summary, I want to hopefully this has been able to I've been able to share with you some of the concerns and issues regarding the state of evidence in pediatric clinical preventive services, as well as some of the barriers and potential solutions to improving that evidence base. Thanks very much. Carrie, I'll turn it back to you.
Okay, thank you for that very interesting talk. So we do have some questions. We've got some time, and we can have some questions and answers. And I'm going to start with a question actually about evidence. And there's been quite a bit of interest in recent years about comparative effectiveness research and comparative effectiveness studies. And you had talked about some about levels of evidence and about emphasis on randomized controlled trials. But is there a role for comparative effectiveness studies? Can these be used in developing recommendations for preventive services? And does the U.S. Preventive Services Task Force look at evidence from comparative effectiveness studies?
Thanks, Carrie. Comparative effectiveness, of course, is a critically important area of research, and it's been championed by a number of groups, most notably the emergence of the new funding agency, PCORI, Patient-Centered Outcomes Research Institute, has a strong emphasis and interest in comparative effectiveness research. It's important to recognize that when doing the types of evidence reviews to establish the effectiveness of the service, you first need to really understand what's the effectiveness of service relative to the absence of a service, for example, or a placebo control. Comparative effectiveness studies can be helpful when you have a baseline of research establishing effectiveness. But in the absence of that, comparative effectiveness studies don't necessarily give you the full picture. So the task force does, and children have used relatively sparsely, in part because the availability of comparative effectiveness research in children, again, is lower than it is in adults. But it has been used in a couple different areas in order for us to be able to understand, particularly when there's different modalities, for example, screening modality, which modalities appear to be superior to others once effectiveness has been established. So there is a role, but I would argue that's actually a secondary role, and particularly in pediatrics, we have more of an acute need and urgency to really get effectiveness studies established before we do more comparative studies.
Okay. Thank you, David. We have one question. Please discuss the role of registries in providing evidence for outcomes in newborn and childhood screening. An important example is sickle cell anemia, where NBS screening and adherence to clinical guidelines result in reduced mortality and morbidity.
Thanks. So I'm not sure. Let me just say that registries and the emergence of registries, particularly with electronic health records, are a potential huge asset for the development of a stronger evidence base. I believe that all of us, as we begin to understand the complexity of the new big data, so to speak, in health, are appreciating the fact that, particularly as we get beyond claims data and into electronic health records data, we have the ability to actually develop these registries, which can be critically important to design and execution of clinical trials for prevention. Many of these registries are disease-focused, and they tend to be ones that serve very well for particularly treatment studies. But in the case of prevention and screening studies, or in the case of even counseling studies, the groups like the Task Force in Prevention are really focused on primary prevention, on asymptomatic people without presence of symptoms and diseases. So disease registries per se have less value for these types of things. And instead, what you really need are ideally are population-based enrollment data, for example, that can come from large integrated health institutions like Group Health or like Kaiser Permanente or other groups like that have, or the military, that have longitudinal databases on people and that have enrollment data that allow you to track them, but capture them before they get sick. But I do want to emphasize the importance and the value of disease registries for clinical effectiveness research.
Okay. So I wanted to ask, and again, this is another data-oriented question. You had talked about how in pediatrics or for children that a lot of the clinical studies tend to be small sample sizes, and so therefore there can be low statistical power. We hear a lot about big data and big databases. And so I think a reasonable question is when there isn't a lot of trial evidence, is there a role for big data to be able to look at some of these important questions and research gaps in children?
Yeah, that's a great question, and I think we need to say that randomized trials aren't always feasible. And they aren't always available. And groups like the Task Force and other groups that create clinical guidelines certainly do consider other forms of evidence. And cohort studies and longitudinal studies are clearly ones that are looked at very carefully. They are more susceptible to bias and confounding than randomized trials, but nonetheless, they do have their own study quality criteria they need to be looked at. So yes, I think the answer is if those data are available, they certainly will be looked at. The problem, of course, is that usually we're looking at secondary use of those data, and the key variables of interest may not always be there. But nonetheless, we need to be always mindful of the fact there's other types of evidence out there that needs to be reviewed. I do want to, a frequent misunderstanding about the task force is that we only do look at trials, and that's absolutely not true. In fact, for a number of these study questions, well, obviously for studies of diagnostic screening and diagnostic test performance, those obviously are not likely to come from trials. So that tells you right away that that's not where we're going to get our evidence. But the same is true for harm. We probably get most of our information from adjunct cohort studies that track people over time to understand what the long-term outcomes are. We also will use longitudinal studies for looking at KQ1 or screening for evidence of screening. So we will not disregard that kind of evidence provided by quality.
Thank you. So NIH has just launched a new 7-year initiative called ECHO, the Environmental Influences on Child Health Outcomes program. Are you familiar with that? And could you comment on whether ECHO might have some promise as an infrastructure or a platform for closing some of the evidence gaps that we've been talking about this morning?
Well, I would say somewhat familiar, but I cannot say by any stretch I've had a deep understanding of ECHO. I do understand that it's a derivative of the National Childhood Study that started before, that was heavily focused on the impact of environmental influences on children. But these longitudinal cohort studies can often be used for multiple purposes, and ECHO certainly should be investigated and looked at very carefully as an opportunity to get some of the information that we're talking about. In part because if the breadth of exposures that's captured for children, as well as the breadth of outcomes that's captured, these we could potentially look at a series of prevention questions for these children. ECHO, as I understand it, is not a disease-focused cohort and could be potentially used. But I think it's something that's well worth looking at. My understanding is that's just sort of getting off the ground at this point.
Thank you. We have another question. Can you provide an example of a preventive service that has changed from an I statement to a recommendation based on new evidence?
Yeah, the one that popped in pediatrics, there's a number of these. And the one that pops into mind immediately is screening for child obesity. That was converted from an I statement to a B recommendation. And the reason that's a good example where there was no problem when it was an I statement. We certainly had sufficient evidence that the screening tool of body mass index, or BMI, had adequate. We had adequate evidence to support that key question. The problem really was more around treatment, and do we have adequate evidence to support treatment of children who are identified as obese? However, in part because of the funders' collective interest in childhood obesity, recognizing, of course, the epidemic that's occurred over the last decades, there had been a wealth of new evidence that had occurred between the time of those two recommendation statements. Between the time that the I statement was issued and the time it was reviewed again, approximately 7 years later, there was a much greater number of treatment studies which were viewed to be where the certainty was viewed to be moderate, and the effectiveness of those studies was viewed to be moderate. So we were able in that circumstance to be able to convert an I statement over to a B statement. So that's probably one of the best examples. Often the gap that's the problem is in the treatment area. Now, as I indicated earlier, harms data are also frequently missing, but at least the task force is comfortable with bounding harms and being able to say that in the absence of that, we can be able to have a pretty good idea, for example, screening tools that are questionnaire-based, or, for example, BMI, which is just based on weight and height. It's reasonable and very plausible to understand that the harms associated with those types of activities are not likely to be greater than small. Of course, labeling is another concern, and we have to take that into consideration. But the task force will sometimes really be willing to bound those harms in the effort to try to make that recommendation.
Thank you for that. I wanted to ask about guidelines. You've talked a lot this morning about U.S. Preventive Services Task Force guidelines, but there are other groups in pediatrics that will develop and issue recommendations or guidelines. And one example is the Bright Futures effort. And sometimes the task force and a group like Bright Futures can look at the same body of evidence but come up with differing recommendations. And could you comment on why that is and whether there might be ways to promote some harmony among guideline groups?
Well, it's a great question, and I think these differences between different bodies around guidelines are not, you provide one example, but clearly across medicine in general, we have a number of perhaps disagreements or differing views around some clinical recommendations. I think that it's important to look at the process that's used to reach those recommendations and to better understand how that process is laid out. So in the case of the task force on Bright Futures, I think the Bright Futures, which is sponsored by one of the NIH agencies and executed through the American Academy of Pediatrics, sees itself sees the process as an evidence-informed process. But I think that it's a somewhat different process to be able to provide and fill in some of the gaps for clinicians where evidence is missing or sparse. And the task force recognizes it's one of the few groups that issues something called an I statement. Many organizations use the grade system to make recommendations. And in the grade system, there is no such thing as an I. There is a weak recommendation that is essentially based on relatively poor quality or weak evidence. But there is no such thing as an I statement, so to speak. So Bright Futures, and I can't speak for them because I don't a part of that process, is really an effort to try to fill in some of those gaps using other sources of information beyond just strict evidence appraisal.
Okay. Well, thank you so much.
I would say that there have been discussions around this issue around child health and efforts to try to work together. But I think that it's safe to say that Bright Futures does look to the task force and uses the information from the task force as part of its process to make recommendations.
Great. Well, thank you so much. I think that's all the time we have for questions. So thank you for all of the useful information. And thank you to everyone who participated today in today's webinar. On the Medicine Mind the Gap website, which is again prevention.nih.gov/mind-the-gap, you will find several resources for this talk, including the slides, references, and a link to complete an evaluation. Your feedback is very important to us as we plan future sessions. Thank you again for your time, and we hope you will join us for the next session in our disease screening series, Defining and Measuring Overdiagnosis, which is to be presented by Dr. Ruth Etzioni on November 18th at 1 o'clock.